I'm curious to go around the group and discuss sort of what are the most common adverse events that you're seeing that are leading to either dose reductions or discontinuations in general with ibrutinib-based therapy.
So I think early on so it depends on the phase of the treatment. Early on, the most common side effect is GI toxicity, but it's usually pretty mild. I haven't had any patient that had to stop treatment, but I did have some occasional cases of severe skin rash that will lead to stopping treatment. But as patients continue on the treatment, the more common reason for stopping treatment would be cardiac events. So cardiac arrhythmia, primarily atrial fibrillation.
So AFib warrants discontinuation,
so I think it's debatable.
Okay.
Depends on what you have as an option, what other options are available. So previously, when we didn't have the other oral targeted therapies available, when you only have ibrutinib, we can manage. Patient can continue treatment as long as they don't have very symptomatic AFib. If they have just an asymptomatic AFib, you can use a rate controlling agents along, depends on the CHEST score. If it's indicated, they can be on anticoagulation, and I would typically choose a novel anticoagulant. And patient can tolerate that and continue treatment. However, if patient has very symptomatic AFib, and so I think that's the point that I would not feel comfortable continuing. But nowadays, you also have other available agents that you can switch to. So I think now I'll be more willing to actually change to a different agent that might have a less potential risk for cardiac toxicity when it's available.
Same answer or?
So slightly different,
okay.
Where I try to stick with ibrutinib for as long as I could. But again, I think if it's a patient that has needed hospitalization for AFib, then we would typically get a cardiology consult, get a comprehensive cardiac evaluation, and then try to reduce the dose of ibrutinib. I know there is little data to suggest that ibrutinib, it's a dose-related phenomenon, but we've typically tried to dose reduce the ibrutinib to see if we could get as much as we could potentially out of ibrutinib. But I think if the AFib persists, particularly if patients are symptomatic or if they need repeated hospitalizations, then I think now, thankfully, we have alternative agents available where we could switch. But if it's an isolated event, it was incidentally discovered on physical exam when a patient was in for their routine clinic visit, then I think it's always a discussion as to how we want to do. What do we really want to do with ibrutinib?
When I was talking about switching treatment, I also agree with you. We want to try to extend the treatment on this pathway blockage as long as possible. So I think now that we have the second generation BTK inhibitor, we might have a good alternative that can allow you still to use this pathway inhibitor without switching the pathways. So rather than switching to venetoclax, for example, I might just choose a second generation agent.
Very fair. So this patient goes on ibrutinib as mentioned, and the symptoms that led to the initiation of therapy resolve after about 6 months on therapy. The splenomegaly, the hepatomegaly resolved, the pleural effusion gradually subsided, although the patient did require multiple thoracenteses in the interim, and lymph node size reduced by approximately 80%. So overall, initially, really great response. And I think the highlighted point here is that the patient was managed through the adverse events in order to achieve that response without having discontinuation due to an adverse event.